Okay, how is glaucoma treated? There you go.
Thank you. Good morning, everyone. Thank you so much for being here, and thank you for having me. My name is Sarah Kuchar. I'm one of the clinical fellows this year, and I have the honor of speaking this morning about how we treat glaucoma. When we talk about treating glaucoma, really our main goal is to lower the pressure in the eye to prevent further damage to the optic nerve and thus prevent further vision loss. That's our goal. And we do that by kind of two main ways. One is to reduce the amount of fluid being made by the eye, and the other is to increase the amount of fluid being drained by the eye. You've heard a few kind of plumbing drainage analogies thus far this morning, and it really does come down to sort of simple plumbing mechanics when we look at how we treat this disease. So, I find it helpful to group our treatments into both medical treatments and surgical treatments. And in most cases, we tend to take sort of a stepwise approach to the treatment of this disease. We often will start with less invasive treatment modalities such as topical medications or some of our laser procedures because they are less invasive, not without side effects, but less invasive. And we reserve some of our more advanced surgical modalities for people with more advanced disease. So this morning I just want to review both our medical treatment options as well as our surgical options that includes laser surgeries, filtering surgeries, drainage device surgery, and I'm not going to spend much time talking about this MIGS, the minimally invasive glaucoma surgical techniques that are somewhat newer. Dr. Mostert did such a great job reviewing the iStent, which was one of our main, kind of our most commonly used MIGS. But I will just mention it as one of our ways of treating this disease. So within the treatment group of medications, we have many different classes of medications, and within each class, different drops. Some drops may be better for certain patients than others. So I'm going to start with talking about the topical beta blockers, which are recognized by their yellow cap color. I often find it helpful to kind of associate the type of drop with the color because it's something that can be more easily remembered than remembering which name goes with which group of medications. And topical beta blockers are very effective at lowering the pressure in the eye, and they do so by getting the eye to make less fluid. And I've listed here some of the more common ones that we see. Timoptic, Istalol, and Batoptic are probably the three that you'll see most commonly. It's important to mention with these drops, and I'm sure many of you are on drops or have been on drops in the past, drops are certainly not without side effects. And one of the things that people can develop is irritation from the drops because the drops are often made with a preservative to help them last longer. So there are sort of preservative-free options out there that the main preservative people have a reaction to usually is something called BAK or benzylalkonium chloride. You may have heard BAK used. And so Timoptic, one of the first ones listed up there, comes in a preservative-free option. And you see I've grouped them into non-selective and selective, and I just want to mention that because Betaxolol or Batoptic, listed as a selective beta blocker, is often used in people who may have some breathing problems because they can have a few less systemic side effects with difficulties breathing. So when we talk about beta blockers, we often consider the side effects, and specifically with this group of medications, we think about some of the systemic side effects. Now, all topical drops can have local side effects, redness, irritation, dryness. But with the beta blockers specifically, we want to do a good kind of comprehensive history of any of your medical conditions because although rare, beta blockers can cause these systemic side effects, which include difficulty breathing or problems with your heart. So we do tend to avoid these medications in patients with asthma, chronic obstructive pulmonary disease, or COPD. So for this type of medication, we want to make sure that the patient is systemically healthy enough to tolerate these drops. The next group of medications that you may or may not be familiar with are the topical adrenergic agonists. And Again, they're recognized by their purple cap color. I've listed two, but really the most common one you see is alpha-GAN. And alpha-GAN works by both reducing the amount of fluid that is produced within the eye, as well as increasing the outflow of fluid from the eye. And it's a very effective drop. It's usually dosed anywhere from 2 to 3 times a day. And it too comes in a sort of a preservative-free form that may be more gentle on the eye for people who have significant reactions to the preservative used in these drops. The side effects of alpha-GAN, in contrast to beta blockers where we spend a little more time focusing on the systemic side effects, alpha-GAN in some unfortunate patients does tend to cause more sort of local ocular side effects. There certainly are systemic, although very low, systemic risks in taking alpha-GAN, and I mentioned a few. Sometimes people may get a higher blood pressure or a higher heart rate, and specifically we do avoid this group of drops in young children. But probably what's more commonly seen are the local side effects, and I have a picture here of what sort of a classic alpha-GAN allergy tends to look like, and it can cause the eyes to be quite red, irritated, develop sort of a bad conjunctivitis, and can cause redness around the surface of the eye. And the unfortunate thing is sometimes this drop works very well, but if you're one of these people that reacts to this drop, it's important that we stop it, to preserve the surface of the eye and make you more comfortable. The next group of medications, they're called Carbonic Anhydrase inhibitors. They're recognized by their orange cap, also very effective at lowering the pressure, and they do so by getting the eye to make less fluid. This class of medication does come in both an oral and a drop form. The drop form, Azopt and Trusopt, are usually dosed 2 to 3 times a day, and again, do come in a preservative-free formula. The oral form we do tend to reserve for sort of our more severe cases where we need, where the pressure is quite high and we need to lower it in a relatively short period of time. This is not a medication we tend to keep people on for long term. The reason for that is because with the oral form there are systemic side effects that can be seen. They range anywhere from numbness and tingling in your fingers. They can change the way that you taste certain foods, somewhat more benign side effects, to more serious side effects including electrolyte imbalances and loss of appetite, dehydration. So these medications, the oral form of this medication tends to be just sort of a short-term type of bridge to an alternative treatment in someone that's not controlled well. We do tend to avoid this class of medications in people with bad kidneys, in people with sickle cell disease, or in people that have a documented sulfa allergy. There's not a great amount of evidence that says that people with a sulfa allergy cannot use these medications, and in certain circumstances, we may consider it. But in general, people with a sulfa allergy, we avoid this class of medication. The prostaglandin analogs, and this is one of our newer drops, although at this point it's been around for over 20 years. But this is a very effective medication, and it has a couple of nice benefits, namely that it's dosed once a day and really should only be used once a day. In fact, it doesn't work as well if you use it more than once a day, which is sort of a better, an easier regimen to tolerate. So it's dosed once daily. We typically recommend people take it at night, and the way that it works is that it increases the outflow of fluid out of the eye. And they're typically recognized by their sort of light green or teal colored top. But again, as you see a pattern, nothing is without side effects. And some of the side effects that you may notice are redness of the eyes. And these are the drops that can, in certain eye colors, change the eye color. And that's actually change the color of the iris. And that can be a permanent change. It can also cause the lashes to grow long, which incidentally is marketed now as Latisse for people that want longer lashes. So some of you are lucky out there; you get free Latisse. But this is a drop that we do avoid in people that are pregnant. So then I'm going to end. Topical cholinergic agonists, recognized by their green top drop. This is not a class of medications that we commonly use. really the only one on this list that has really any real relevance is pilocarpine. Pilocarpine works by increasing the outflow of fluid out of the eye. It does so by sort of constricting the pupil. So you'll notice when you're on this drop, if you're on this drop, your pupil is quite small. It has efficacy in some patients. It's not one of the more efficacious drops that we have, and so we often reserve it for sort of more of a kind of a last sort of effort to try and lower the pressure topically before moving on to sort of more invasive techniques. But for some people, it does work well. It does have some systemic side effects as listed here, but I would say sort of more often we see more local side effects that can cause sort of a brow ache. It can cause you to become more nearsighted, and we do tend to avoid it in patients that either have had retinal issues in the past or may be at risk for developing problems with their retina. So why do medications fail? Because I mentioned with all those drops, they all kind of work effectively to either reduce the amount of fluid being produced or increase the outflow. There are a few reasons. Poor compliance or difficulty adhering to some of these very difficult drop regimens that we prescribe, or sometimes poor technique, drop technique. I can speak from personal experience, having had to go on a drop. It's way more difficult than I would have ever imagined. So, you have to really recognize that it's not always easy to have 3 or 4 drops on board and asking you to put the drops in 2 to 3 times a day. So that can be a reason why the medications don't work, because it's difficult to get them in always. As I mentioned, none of these drops are without side effects, and sometimes you reach a point where the eye just becomes intolerant of the drop. You just can't, continue to take it because it's irritating and can be causing other problems in the eye. The pressure may be fluctuating in between doses, and you may progress even if you're getting the drop in all the time, because the state of your disease may reach a point where drops are no longer sufficient to lower the pressure enough to prevent further optic nerve damage and further vision loss. Of these reasons why medications may fail, the sort of doctor-patient relationship can at least focus on sort of poor compliance and poor technique to try and adjust those so that we can increase the efficacy of the drops and sort of delay surgery. And so, this picture, I mentioned this website because for anyone that hasn't been to this website, it actually gives really nice illustrations and very short videos on sort of good techniques for administering drops. And so the picture I have here, you have the patient, we encourage people to lean their head all the way back, get gravity on your side, pull the lower lid down so you're creating a little pocket in the eye to kind of catch the drop. You only need one, and even one drop going in, you're going to notice some runs down the face, and that's okay. You don't want to be putting 2 and 3, not because you can overdose on the drop, but because these drops are expensive and you're going to run out of them sooner. And then you'll see in this picture, the third one down, she's putting her finger sort of in the corner of her eye. We encourage patients to do this because your tear drains out of a little hole in the corner of your eye here. So by closing off that drainage system, you give more time for the medicine to stay on the surface of the eye and get absorbed. So you're kind of getting more bang for your buck, so to speak. And then waiting at least 5 minutes, don't really need to wait too much more than that, in between each drop, so that you give that full time for that medicine to be absorbed before putting in another drop that could potentially wash out the first drop you put in. So, just reviewing those techniques and trying to, find a good way to put a drop in can really improve the efficacy of these medications. And then to address sort of the adherence to these drop regimens, luckily we've had some combination drops that have come to the market. We have Simbrinza, which is a combination of alphagan and brinzolamide, Combigan, which is a combination of alphagan and timolol, and then Cosopt, which is a combination of timolol and dorzolamide. And the beauty of the combination drops is it gets you on one less bottle. So you get, 2 for 1. And the fewer bottles that you have to have at home and the fewer times you're putting drops in the eye, higher the chance of remembering to do it. And so certainly both good technique and, taking advantage of these combination formulas can, improve the efficacy of these topical medications. So now we'll move on to glaucoma surgery. And I'll start with laser surgery, specifically the trabeculoplasty. Trabeculoplasty is actually often a treatment that we'll offer early on in the disease process, sometimes even as an initial treatment before starting any medications. And there are two types of trabeculoplasty. You'll hear us talk about argon laser trabeculoplasty and selective laser trabeculoplasty. For all intent and purpose, they both do the same thing. It's a different type of laser that we use, but sometimes they'll be shortened to ALT or SLT. And I just have the two pictured here. But the trabeculoplasty is used for people with open-angle glaucoma. Just heard in the last lecture sort of when you saw the picture of both open and closed. This is for people with open-angle glaucoma. And the goal is to sort of clean out and open up the trabecular meshwork, which is, in a sense, the eye's natural drain. So it's cleaning out, kind of opening up the eye's natural drain. And for 80% of patients, they really have a nice response rate to this. Now, it's not a permanent fix. It tends to work pretty well in the first couple of years and less well kind of 3 to 5 years out. But the good news is, we can repeat it. If it worked well for you, we can repeat it up to, 2, sometimes even 3 times. And it's nice for compliance because it's a one-and-done type of treatment. And if it works and it lowers your pressure, we can delay starting drops or delay adding another drop. And it's generally nicely, very well tolerated. Usually people report a little bit of irritation, inflammation for the few days after the laser. But in general, people tolerate this very well. Next laser procedure that we'll do earlier on in the course is what's called a laser peripheral iridotomy, or you'll hear us refer to it as a LPI or a PI. So we had SLT, ALT before, now we have LPI or a PI. We make a small hole in the peripheral iris, that colored structure inside the eye. And we do this for people with what we call narrow angles. And this is a predisposition to developing closure of your angle where your eye's natural drain sits. We also do it for people that have actually started to develop what's called angle closure glaucoma, where we already see evidence of some scarring in the eye's natural drain. And what it does is it allows fluid to go from the back of the eye through this hole in the iris, in the colored part of the eye, and into the front of the eye. And kind of balancing out those two compartments of the eye will allow the fluid in the front of the eye to kind of push the iris back, get it out from clogging the drain, make it easier for fluid to access the eye's natural drain, and hopefully either, one, prevent what we call an acute angle closure attack, which is when in someone predisposed to this because of their narrow angles, their drain can close off quite suddenly and the pressure can rise up quite high. It's one of our few kind of ophthalmic emergencies. Or two, in someone that's starting to develop evidence of sort of slow chronic scarring of the drain in the eye, it can prevent additional scarring. This laser in and of itself does not lower the pressure. It sort of temporizes a process going on in the eye that could either cause an acute rise in pressure or a slow gradual rise in pressure. And finally, we have what's called cycloablative laser treatment. You've heard before, when we talked about the anatomy of the eye, there's a structure in the eye called the ciliary body, and this is where the fluid of the eye, or the aqueous humor, is made. So this type of laser is designed to really destroy part of this structure in the eye so that you're turning down the faucet, you're getting the eye to make less fluid. We have 2 different types of this laser. The first one is endoscopic cyclophotocoagulation. This is why we have so many, 2 to 3 letter acronyms, because no one wants to say these words all the time. So we have SLT, we have PI, now we have ECP or CPC. This is often done for more mild to moderate disease earlier in the course, and is, it may be offered in combination with cataract surgery. It's better tolerated because it is more selective. This is laser treatment that we do during surgery because we're actually inside the eye, looking right at the structure that makes the fluid in the eye, the ciliary body, and targeting the laser right to that structure. Versus CPC, benefit is that we don't have to enter the eye. It's an easier tolerated surgery, but we do use it in more advanced disease because this is laser that starts on the outside of the eye and targets the structure from the outside of the eye. And because of that, it tends to be associated with more inflammation after this type of laser. And so because it's associated with higher risks, and we reserve it for people with more advanced disease because it is riskier, although very effective in lowering the pressure. Okay, so we've covered laser surgery and procedures. Now we'll talk about filtering surgery, and the main filtering, the filtering surgery being called the trabeculectomy. This is one of our most commonly performed and most effective surgical means of controlling this disease. And again, if we go back to remembering why, what our goals are, we're trying to lower the pressure in the eye. And so in this surgery, we're making, the eye's natural drain is no longer functioning, be it because it's closed and scarred off, or it's open and just not working anymore. And so our goal is to make an alternate pathway for the fluid to drain out of the eye. So how do we do that? Well, in the trabeculectomy, what we do is in the outer covering of the eye, the sclera, we make a partial thickness flap in the eye. And underneath that flap, we actually make a small hole into the eye through which fluid can directly drain out. Now, if we just left that hole open, we wouldn't be able to have great control over how much fluid was flowing out of the eye, and the eye could get too soft. So we use that partial thickness flap that I have depicted in that first picture up here to then cover back over the hole so that we can sort of control to an extent how much fluid is flowing out. So in this picture, you see this is your ciliary body. Your fluid is made here. It travels to the front part of the eye. In a normal, healthy eye, it could drain out of the natural drain that sits right in this angle. But in someone with bad glaucoma, that's no longer working, so it goes out the hole that we make and collects underneath the flap that we made. Then we take the eye's natural coverings, the conjunctiva, and cover up that flap so that the fluid that's sort of leaking out underneath that flap can collect under the eye's natural coverings and create what we call a bleb, or a little pocket of fluid underneath the conjunctiva. And so if you've had this surgery or know anyone that's had this surgery and you've been with them to an office visit after they've had the surgery, you'll often hear the doctor refer to the bleb. And that gives us a sense of how well this filtering surgery is working, because if we see a nice elevated pocket of fluid, we know the fluid is effectively flowing through this new drain that we made from the inside of the eye to the outside of the eye and keeping the pressure low within the eye. And this is just a clinical picture of what a bleb may look like. So that's the trabeculectomy. We also have drainage device surgery, or the tube shunt. And the idea of the tube shunt is similar to the trabeculectomy. The drain in the eye isn't working, so let's make a new drain. In this case, we implant a device in the eye that functions as a new alternate drain. And so the tube shunt is comprised of the tube here and a plate that helps anchor the tube to the eye. So we make a little pocket in the eye's outer coverings. We place the plate of the tube in that little pocket. We cut the tube to the appropriate size so it can fit nicely inside the eye. And then we secure it with stitches to the eye so that it's not going to move or come out. And now fluid can flow from the inside of the eye through this tube and collect on the outside of the eye. And eventually your body just resorbs that fluid. And that's a clinical picture of what a tube inside the eye looks like. And that's what, when we see you after we've done this surgery, that's what we're looking at. We want to make sure the tube is in good position, that it's inside the front of the eye, and we look on the outside to see if we can get a sense that fluid is collecting as it should and that the pressure is staying low. The Express mini shunt, I kind of had follow the trabeculectomy and the tube shunt because you may have heard of a mini shunt or the Express, and really this type of surgery is sort of a combination of the two that I just reviewed. Parts of the surgery are like the trabeculectomy and parts are like the tube shunt. So in this surgery, we do make sort of that partial thickness flap, but instead of making a small, just natural hole in the eye, we place this tiny little mini tube in there and cover it back over with this flap. And for some patients, this is a nice option. It can be a little bit more controlled in terms of how much fluid can come out. And really the take-home is between the trabeculectomy, the tube shunt, or the express mini shunt. It becomes a little bit a discussion between the doctor and patient and what they think that the individual eye will tolerate best. All of them have that common goal of taking fluid inside the eye and moving it to the outside of the eye. But the reason that we tend to reserve surgical options for people that have shown that they are sort of progressing despite us trying less invasive treatments such as medicines or some of our lasers is because certainly no surgery is without complications. And so, unfortunately we don't have a great way. We talked about trying to make this alternative drain, and there is the chance that the new drain we make can work too well, and that too much fluid can leave the eye, leaving the eye too soft, and we call that hypotony. And hypotony can lead to decreased vision and swelling in parts of the eye, and even bleeding. And then, of course, surgery in the eye is not unlike surgery anywhere in the body, in that it can leave you predisposed to infection. Thankfully, things like infection and total vision loss are rare. Our surgeries tend to work very well, but everyone needs to be aware of the risk they're taking on, and that's why we sort of, it's a very detailed, comprehensive discussion between the doctor and the patient when they reach the point of needing surgery, so that they understand that it is a long, hard road to recovery. And there, we talk about the roller coaster ride that is the post-operative period in glaucoma, and that's because the pressure can fluctuate a lot, and you can be dealing with some blurry vision for quite some time until the eye gets used to this new drain. Because of some of the complications with more invasive surgery, there's been sort of a lot of research directed at these minimally invasive, less invasive glaucoma surgical techniques, or MIGS, as you may hear them referred to. And again, Dr. Moster did such a great review of the eye stent, which is one of the more common MIGS. But the goal here is to lower the pressure, but if we can minimize how invasive the surgery is, we minimize the side effects. Now, we don't live in a perfect world, and the caveat is the less invasive the surgery, sometimes the less effective it can be at lowering the pressure. And for that reason, we have to be careful about who we select for these types of surgeries, and often it's patients with more mild to moderate disease. And so, the name of the game in surgery is just targeting the right surgery for your eye. And so I just list a few of the MIGS surgeries that we have, and certainly, more to come as there's more research being devoted to this. So in conclusion, glaucoma, unfortunately, at this point, is not curable, but it is treatable. And I hope I've shown you there's a variety of treatment options available and given you a sense of how we approach treating glaucoma, why we may choose one treatment modality over another for a certain patient or a certain type of glaucoma. But really, early detection is the key, because these treatments are very effective at dramatically slowing down the progression of this disease and making it so that a patient in their lifetime will not develop meaningful visual loss. But if we're already starting so late into the disease, unfortunately, people can have significant vision loss from glaucoma. So early detection is really the key. There's screening going on upstairs. And finally, just good communication and close follow-up just certainly increases the chances of avoiding meaningful vision loss in your lifetime. So it's up to the physician to clearly explain sort of what you have and why you have it and why we're treating it the way we are, and then it's up to the patient to certainly ask questions and just get a good handle on why they're on the treatment that they're on, so that they can understand how better to prevent further vision loss. So I thank you for having me, thank you for coming, and enjoy the rest of the day.